Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
In tonight's episode, we're diving into an exciting and rapidly evolving area in cancer care, which is sometimes called liquid biopsies. Other people will refer to this as circulating tumor DNA or ctDNA. These cutting-edge technologies are transforming the way we potentially detect, monitor, and treat cancer. And you'll be hearing a little tonight about how a very promising test may in some ways be ready for prime time, in other ways not be ready for prime time. And we'll very much touch on that. To help us better understand how liquid biopsies work and what they mean for patients in the future of cancer care, we're joined tonight by Dr. Heather Parsons, a leading expert in this field. Heather is a medical oncologist and cancer researcher who I worked with for many years at Dana-Farber Cancer Institute in Boston, and who has recently moved to Seattle, where she is about to lead the breast cancer program at the Fred Hutch Cancer Center. Heather, good evening. Great to have you join us tonight.
Thanks so much, Eric. It's great to be here.
So we're going to just jump in. And by the way, I'll tell the audience, Heather is also, like me, a breast cancer doctor. So we may touch more on issues related to breast cancer than other cancers. But what we're talking about tonight really applies to many different kinds of cancer. But maybe you could start off and tell us, what exactly is a liquid biopsy and how does it differ from, for example, a traditional tissue biopsy? What do we measure when we're talking about liquid biopsies?
Sure. So liquid biopsy is really a very general term that means we're taking a sample of fluid from the body. It's usually from the blood, but it could also be from somewhere else, to characterize or understand the underlying cancer. So it's not, and when we think about a liquid biopsy, we're usually looking for certain cancer-related, I'll say, substances, which could be something like cells, for instance, circulating tumor cells that are cancer cells floating around. But more commonly lately, what we've been talking about is what you referenced is circulating tumor DNA, sometimes called ctDNA. You could also look for proteins and other things, but these are used to answer a question that you have about the cancer.
And I think it's probably fair to say that for many years we were looking at circulating tumor cells, and that didn't really take us very far doing that. And I think most people have gone away from measuring CTCs or circulating tumor cells. Is that accurate?
I think that's accurate. There are always people who are still looking into whether the technologies can be improved and we can find more of them and do more things with them. But right now, for sure, this is not, circulating tumor cells are not what most people are focused on to be, sort of be part of a liquid biopsy for a patient with cancer.
And initially, it sort of amazed me that in the blood we could find circulating tumor DNA. But then I actually thought about it. And of course, in a very different setting, that is in the setting of pregnancy, we've almost stopped doing amniocentesis. And that's because in that setting, we can find circulating fetal DNA. Do you want to comment about that a little bit?
Yeah, so it's really interesting. The field actually, we think about circulating nucleic acids, which is a fancy way of saying DNA or RNA, but the sort of messages that are stored inside our cells. And it goes all the way back to the 1940s when some scientists in France figured out that these nucleic acids were floating around. And then in the 70s, people started looking at how you could use this in pregnancy to understand things like trisomies or other kinds of problems that can arise in a fetus, which we used to have to do amniocentesis for, which obviously has some dangers to it. So it took until, this century, probably about 10, 15 years or so ago, when people started really thinking about this in earnest in a real way to do in cancer, but it's really taken hold. But it does go back to pregnancy and fetal DNA for sure.
And when we're talking about circulating tumor DNA, does this have the potential to detect cancers or to monitor cancer, cancer that someone has and they're undergoing treatment, for example?
Yeah, so this is one interesting thing about ctDNA is that you could think about it all the way through from before someone's been diagnosed with cancer as potentially a diagnostic test, a screening test, all the way through to somebody who has very advanced cancer and maybe directing their therapies or guiding, understanding what's happening. So it really depends on I always go back to what question are you asking? And it's important that you know what question you're asking about the cancer before you start to do a test. But you can be very broad in how you think about what the potential for these ctDNA tests are. And people are thinking in that way.
And do you think that at some point in the future, we will not be doing tests like mammography and instead using blood tests to try to detect breast cancer in its earliest possible stage? Or, for example, will we be getting away from colonoscopies and measuring something in the blood?
Yeah. So, each setting is a little bit different. And I think in colonoscopies, which is obviously a test nobody loves, we're already using
your favorite test.
circulating DNA in a little bit of a different fashion from the stool to be used as a screening test. And that's already being used regularly and is approved for that purpose. Mammography is a little more challenging because it's a little bit less of an onerous test for most people. And it also is it's good enough in terms of how it detects breast cancer, although certainly not perfect. And so the standard for which it has to compete, a new screening test has to compete, is a little bit higher. The screening tests in breast cancer from circulating tumor DNA haven't been as promising as in some other settings, some other cancer settings.
And of course, the other problem two different problems for breast and colorectal cancer. So in breast cancer, if you got a positive test result and you didn't see anything on a mammogram or an ultrasound, what would you do? I mean, it's really hard to know what one should do. And in the colon cancer setting, you can use it as a screen, but it doesn't totally eliminate the colonoscopy because colonoscopies are both diagnostic and therapeutic because you can go in and remove polyps.
Exactly. So in the colonoscopy case, this would be a first step. And then the second step is to be able to do the colonoscopy after a fecal DNA test. But it is for some people who wouldn't, understandably don't want to go through a colonoscopy and have no other high risk features that make them need that first as a test. It can be a helpful first point to start with.
And to give people a sense of how commonly you see this in somebody who has early stage cancer, whether that's breast cancer or lung cancer or some other relatively early stage cancer, how often do we find tumor DNA in the blood? It's not 100% by any means.
No, it's definitely not 100%. And it depends very much on the setting. So how far along is the cancer? So a higher stage, more advanced cancer will be more likely to be detectable. And also, what's the cancer type? So a aggressive breast cancer that grows more quickly, like a triple negative breast cancer, is more likely to be found than maybe a slower growing tumor. And there are other things that make it more or less likely to be found, but it can vary anywhere from 100% of the time, which is not most settings, to down to, a quarter of the time that you would find something if it's there.
And because we're going to get to this topic probably in the next half of the show, but these are not personalized tests because we do have the ability to look at tumor DNA that we know is from someone's tumor or is similar to someone's tumor. And then, of course, these are just non-specific tests that we're talking about in the setting of early stage disease.
Right. So in early stage disease, the challenge really is that you have to find a test that's both sort of tunes the test to be both sensitive enough, meaning it picks it up if it's there, and specific enough, meaning it doesn't see it if it's not there. So that's a little bit more challenging when you're looking for something across many different kinds of cancers and even just across one kind of cancer among many different people. Even
across all breast cancers, because
right.
because we know that one woman's breast cancer may be different from another woman's. That's a very common problem. And of course, different people are different, which might to some extent affect this.
Exactly. And since cancer is in part or in large part a disease of the DNA changing, each cancer by sort of definition has different changes in the DNA code. And so each cancer is different at that level, and it makes it harder to find a test that can capture all the different kinds of cancer.
Yeah, I often say that cancer is part self, meaning it comes from us, and part non-self because it's changed from the cells it originally arose from.
Right. And it's what makes it so hard to treat too, right? And sometimes.
No. Yeah. Absolutely. Now, one of the major challenges with all tests are false positives. So you get a test result and it gets you all worried. This happens with mammography. It happens with exercise treadmill tests that, sometimes a test will be positive, but the person is truly, totally well. Is that a problem here?
So in a screening test, it certainly is a problem. So this goes back to those tests where we're looking for cancer, even if it's not known. So screening tests like mammography. And it is certainly a problem, and you have to tune it to how specific you want it to be. So if the test is positive, how often you want it to be a true positive, meaning that it's really there. But that often is at the cost of a less sensitive test. So it's a little bit tricky in this screening setting to figure that out, what the right answer is.
Are there any settings now, again in 2025, where we're using these tests as screening tests to identify a new diagnosis of cancer? Somebody who's totally well and we're just doing a screening.
So the tests are available. There's one test in particular that's available, although it's not usually covered by insurance, and I don't recommend people getting it. In the UK, there's a very large study going on across the country to see whether they're called multi-cancer early detection tests, or MCED tests, whether this is a test that will benefit people. And it's a complicated study design, but it's ongoing, and we'll hope that those results are promising. But right now, it's not recommended by any recommending bodies, and I certainly don't recommend them, but people can get them if they like.
Well, we're going to have to take just a brief break. I will return with our guest, Dr. Heather Parsons, who is the leader of the breast cancer group at Fred Hutch Cancer Center, or will be in that role in just a few weeks, and who does research related to circulating tumor DNA. We'll be right back.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital. which provides a multidisciplinary approach for treating appendix cancer, including advanced surgical techniques like hypothermic intraperitoneal chemotherapy. Learn more at smilocancerhospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Milo Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. I'm Eric Weiner, and tonight I'm speaking with Dr. Heather Parsons, a medical oncologist and cancer researcher at Fred Hutch in Seattle, Washington. And we're talking about liquid biopsies or circulating tumor DNA. Before we get back into the sort of nitty-gritty of liquid biopsies, maybe you could just spend a minute telling us how you ever got interested in this area.
I actually had a background that's, I would say, is not super common, both in the lab, studying, doing some more sort of basic science lab research, and in public health. And I was, because of those two combinations, which some people say is like a political science background, in sort of from a sort of socialist perspective or a capitalist perspective, like is it individual or the public good? And I thought biomarkers seemed like the most amazing way to maybe kind of get at this combination. And I met Dr. Ben Park at Johns Hopkins when I was a fellow there, and learned about circulating tumor DNA, which was in its infancy. He had studied with Dr. Bert Vogelstein there. And it just blew my mind to think that you could possibly use these little bits of cancer floating in the blood and figure out exactly who needed treatment and who didn't, if it were to work. And I got lucky, and it seems like it's gone pretty far. So gone pretty well so far.
Yeah, no, I think that your career has sort of tracked the history or the modern history of circulating tumor DNA. So you've been able to both take advantage of what's gone on, but also have contributed so much. Let's talk about using circulating tumor DNA in somebody who's already been diagnosed with cancer, and how one might do that. And that's an area where we're beginning to do this. We're certainly doing it in a research setting, and where I think you and I agree that there's a lot of promise here. So talk a little bit about what we're doing now in patients who have cancer with this marker.
In the regular clinic, so when you and I see patients in our breast cancer clinics, we are already using liquid biopsy tests right now to help our patients with advanced cancer and figure out what kinds of treatments might be the right treatments for them. And so I'd say that's sort of our already sort of 2025, where we're at, how we're using these tests now. And that's true in other types of cancer as well, not just breast cancer.
And if I can just ask, for a number of years, we've used tissue biopsies that we've done gene profiling on, where we try to really understand the genes that are turned on and off in a given cancer. And so are you saying that we can now, instead of getting a tissue biopsy, which often involves either occasionally a surgery or at a minimum a big needle that you don't really want to have someone putting in your body, that instead we could use a blood sample?
So yes, we are in most cases, with some small caveats. It is right now. That's exactly what we're doing in clinic. And if the cancer is under good control or some other, there's only a tiny bit of cancer in the body, even if it's spread to other places in the body, it can be harder to detect the ctDNA. So to answer those questions by the blood biopsy, by the liquid biopsy. But for most people, it's actually a very effective, much easier way to get the information we want about the cancer.
And of course, when the cancer is under good control and someone's doing fine, we may not need the information at that point in time. And
Exactly.
We need it when things are getting worse.
Right. Exactly.
And is this a test that you can get repeatedly over time and you can potentially observe changes in the cancer over time?
Yes. And I think this is one of the most, in the advanced cancer setting especially, is one of the most helpful parts of it, is that you don't want, as you said, sticking a large needle into your body is not what anyone wants to do on a regular basis. And yet doing a blood sample, our patients are willing to undergo those every few weeks and without a lot of trouble. And so it's easier to do this and to see a cancer evolve. And even in some cases right now in our clinics, to be able to give a different treatment than we would have otherwise given because of the results of a test that we can do again and again.
And do you think that this is now a pretty standard approach in taking care of patients? For example, because I know it the best, patients who have metastatic or advanced breast cancer, that getting these liquid biopsies, these circulating tumor DNA measurements, I think this is one place where I think you're going to agree, we could say that this is a pretty standard thing to do.
Absolutely. I recommend if somebody hasn't had this test, especially in certain advanced cancer settings, that they should be getting this test for sure.
And, for sure, we have to be thoughtful about the timing of the tests. And as with any test, we don't want to overuse it, but it's something that I think most of us feel could be helpful. Let's move to a different setting. And the setting is someone has undergone treatment for their breast cancer. So somebody who had cancer that has not spread outside of the breast or the lymph nodes, they've undergone what they and their doctors believe is potentially curative treatment. And there are some doctors who actually in that setting get these non-specific circulating tumor DNA tests. What's your opinion about that?
So in that setting, I recommend full stop not to get these types of tests. And we'll get, I think, to another setting, another type of test that we're more interested in doing, but though we need to study it. But the problem with these types of non-tumor specific tests are that, and in that setting where someone's undergone what we think is curative treatment, is that they can pick up other kinds of changes in the blood, which are not actually coming from the cancer. So they could pick up changes in the white blood cells, which are very common and not something we need to react to, sometimes called CHIP or clonal hematopoiesis. That can be a problem in terms of we think we see a mutation that's coming from the cancer and everyone gets very nervous. And actually, that's not what it is. And the other problem is sort of the opposite, which is that they're actually not very sensitive. They're not very good tests for what you would be asking. So in that setting, most people are asking, did the cancer come back? And should I be doing something about it sooner rather than later? And these tests are only going to pick up cancer DNA when there's a lot of it around, or more than would be around at these very early stages of a cancer potentially returning. And so I would recommend against using those tests in that setting.
Well, I like the full stop approach. And you and I have both been involved in a study, you led it, in which we actually looked at circulating tumor DNA in patients who were a number of years out from a diagnosis of breast cancer. And in fact, in that setting, it was predictive of patients having recurrences. But then there's another problem, which is that we don't know quite when that's going to happen, and we don't really know what to do with the information. And I often say to patients that if we don't have evidence that a treatment is going to make you live either longer or better, it's hard to pursue it. And so my guess is you agree with that.
Absolutely. And I think that study was exciting, but also scary in that it was so strongly predictive of patients having a recurrence, even though they had cancer, years before. But absolutely, the problem is we don't know if we gave them treatment right then when the test was positive, is it going to help them live better, live longer? We don't know the answer to that. And I think that's the really crucial thing that we need to study. One other thing I would add about that study and what compared to what we just spoke about is that that's using a different kind of test that's designed specifically for looking for tiny bits of cancer in the blood rather than for it's for bits of cancer that help us guide somebody's therapy later on. So it's a very different way of doing the test, and it matters because we want to use the right test in the right setting.
No, absolutely. And, this gets at sort of another more general issue, which is when do you apply a new technology? When do you start to use it? And there are all sorts of tests that we have a hunch will be better in the future. And I think this is one where both you and I have this hunch that there are going to be a number of different settings where we use ctDNA to help diagnose recurrences earlier. But we're just not, we're not there yet. As I sometimes say, not ready for prime time.
Right. And how many times have I been asked to give a talk called, is it ready for ctDNA ready for prime time? It is a lot, I would say. But it's true. And it's frustrating because when we think of, when we have a medicine that we think is really promising, we do really rigorous studies to figure out, is it safe? Does it work? Should we use it in patients? And then we have a specific way in the United States and in Europe, how we get those medicines approved. And for tests, for better or worse, and sometimes for worse, we get these tests, we can use them as soon as they become available before we prove that they work. And so I think that's the big thing that's on us, is to be able to prove that these tests make a difference for patients.
Yeah, no. And I think that for a lot of patients with all sorts of different types of cancer, there are many ways in which we can use tests prematurely, sometimes come to the wrong conclusion, sometimes do a lot of harm. And there's a real process that we have to go through scientifically to prove that something's going to be useful for someone. And without that, it's really difficult. Do you have any closing thoughts as we wrap this up? Anything you want to tell the audience?
I would tell the audience that I would advocate for, and I, as a researcher, this is probably a no-brainer, but advocate for patients to participate in studies and to advocate for studies with this type of technology, because it's incredibly promising, but there is a lot we need to learn before we should be using them all the time in all the patients.
Dr. Heather Parsons is a medical oncologist and cancer researcher. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.